The last but not least speaker in this session is Dietmar Hutmacher. He is Professor and Chair of Regenerative Medicine at the Queensland University of Technology and has an adjunct appointment at the Georgia Institute of Technology in Atlanta, Georgia. In 2012, he was awarded an ARC Future Fellowship, and in 2013 was awarded the Hans Fischer Senior Fellowship at the Technical University of Munich. His background is in academia and industry, and his expertise is in biomaterials, biomechanics, mechanical devices, and tissue engineering. He presently leads a successful multidisciplinary team of engineers, cell biologists, polymer chemists, clinicians, and veterinary surgeons, with the aim of delivering translational outcomes in 3D printing of both synthetic and biological materials. I think this is evidence of a person with excellent leadership skills, and the work that he's delivering is identifying him as a pioneer in additive biomanufacturing. Please welcome to the podium Professor Dietmar Hutmacher to talk to us about 3D printing in medicine.
Thank you. I also want to thank the Academy for inviting me to give this talk today on the topic of 3D printing, which you all might think is, when you look at the famous hype curve, very hype and so on. And I think it's quite important. What I try to tell you today is what is hype and where the reality is. And yesterday we had the chief scientist talking to us about where he sees the future in 20 years. So maybe if you think about 3D printing, you might think this is the future.
We had to build your friend Loomis a whole new ear from scratch. What we're suggesting for you, Archer, isn't a permanent transplant like that. Just a temporary trade. Come here. With the new anti-inflammatories, healing takes days, not weeks. Your blood types won't match, but Pollux won't know that. Height difference is negligible. Skin pigment, eye pigment, both almost identical. We'll use laser shears for the hairline, micro plugs for body hair. We'll do an abdominoplasty, take care of those love handles. But all that's the easy part. Here's the real science.
This is a famous part of this movie, which some of you might know, called Face Off. Here is the real science. So this is a movie I recommend to any student who comes into my lab to watch, because that's not what we are doing. We really want to work on the science of 3D printing, and we want to make it a reality, as it is already a reality also in the clinic. As you see with this was the first 3D printed total jaw, designed and manufactured by additive biomanufacturing, implanted more than 2 years ago in Holland. I'm not going to present. There's also great work coming out from Australia, from Anatomics. I think Gordon Wallace will cover this. Then this is the reality. This is work by a good friend and colleague of mine, Scott Hollister from Michigan, where they have developed a stent system, which is also 3D printed, which is used in children which have problems with their airways, where the airways needs to be regenerated, and they print this resorbable stent, which have been covered by journals like Nature and so on. And again, this is a specific design, and this design looks simple, but it's really one of the importance is that these stents are custom-made. They are made by a process which we call selective laser sintering by using a biodegradable implant. And there's now a large cohort study going on funded by NIH. So when I started out more than 15 years ago, coming from industry, developing biodegradable implants, when I did my PhD in Singapore, we started a process which is called fused deposition modeling, where we designed implants by a 3D printing process which allow us to make this patient-specific implants, as you can see here. This is a child we treated a number of years back in Germany, which has a congenital defect of the skull. It was treated 2 times with a bone graft. The bone graft didn't take. And there would be an easy solution to treat this defect with a titanium plate. But as this child is still very young, the skull bone is still growing, so you have to do 1 or 2 operations. So using now a biodegradable implant, custom-made, you see here this complex shape, which exactly fits into the defect site. No cutting for the surgeon, fixation with spiroresorbable pins. And then in this case, it was a great biological advantage to have a child because we were able to raise what is called a periostal flap over the scaffold, and we did not need to add any more biological competence in form of growth factors or cells to regenerate this defect. So this is a reality. These implants have been implanted in thousands of patients around the world. They are FDA approved as well as CE marked in Germany. But this is obviously just one application of 3D printing. This is another patient we treated, a very complex tibia fracture. Again, multiple bone grafts which didn't work. And here we combined the scaffold now with bone morphogenetic proteins because that patient was already 64-year-old. So we needed to bring in some more biological stimulation. All right. So again, from a technology point of view, we have to look at printing like we look at printing. And here you see the evolvement of the field. And we think now the decade is ripe to really move very strongly into bioprinting, biomanufacturing. But we have to get a number of things right. And again, from a technology point of view, we can already do a lot of things. But the big question is, how do we direct the biology? And again, if you want to have a nice read, then I would recommend that you go to this web page, which is called Future. And they show very interesting and in a style information which is easy to uptake. But they also give a lot of times very wrong impressions. So here you see this graphical illustration of a printer, and that printer is printing a heart. We will never ever see, not even in the next 500 years, that we can print tissue or that we can print the organ. What we can do is we can print cells. But the question is, how do we print the cells that these cells then proliferate, migrate, develop the extracellular matrix, develop the tissue, and then maybe one day we are able to direct multiple tissues to form an organ. So again, this is a very wrong perception of 3D printing. We cannot print tissues, we cannot print organs, but we can print cells. But that leads now to different applications. So for example, if you think here about this graphical illustration, where we want to regenerate part of the cornea. If we just want to regenerate the epithelial side of the cornea, which is a single layer of cells, then we might be able to do this with printing cells onto the cornea. Or with wound healing, if you just want to, again, treat or replace the keratinocytes, the superficial cells, then we might be able to do that. But most of the time, the difficult problems in the clinic is not just one cell layer. It's usually a combination of the epithelial side as well as the stroma, and we have to find solutions for this. So this leads us to the complexity. So here you see us printing cells in a hydrogel. But some of the issues is that, and I get to this in a moment, that we need to develop these biomaterials which are highly cell compatible, but which allow us not just to print the strands in one layer, but really to build this up and get to dimensions in the Z direction, which are 1 centimeter, 2 centimeters, 3 centimeters. And this is a big challenge for us to do this also with a very high spatial resolution, because that is needed because we want to direct the cells to form the tissue which we desire to do. So again, so one side of 3D printing is that we have to develop what we call these bioinks, where we really look from a technology and material science point of view, what is the best way to really print now these biomaterials, to have high spatial resolution, ship validity, and so on. But one of the challenges we are facing is, if we want to have something which is able to do that, for example, we are looking at mechanical properties, that we have shape fidelity. So this is normally done in the chemistry, as you see down here, where we can play around with a polymer, with the molecular weight, the concentrations, the cross-linking density, and the stiffness. But specifically, if we change the cross-linking density and stiffness, this has a major effect on the cells, and that effect is negative. Our cells cannot proliferate anymore. If we use very high cross-linking densities, we need to use chemistry, which are damaging to the cells and so on. So therefore, we talk about this window where we really have to find the compromise from the material side, the technology side, as well as the biology. And there are different 3D printing technologies which all relate to this. So we published this review about 3 years ago, which is cited now more than 250 times. My postdoc was really disappointed because it went through 9 revisions before we submitted it. But as you can see here in this figure, this summarizes the complexity. This is a multi-parametric process. And again, it's the mixture of the printing itself and then what we do with the cells when we use them in the system. So my group and also the group of Gordon Wallace, as he will tell you later on, we focus a lot of our work really to develop now materials which fulfill criteria which are related to this chart. And we are doing the science also that describes it so that we can do the control of the system. Okay, so one of the other issues then is if we go to high load-bearing tissues, like we work on musculoskeletal tissues like bone, cartilage, or heart valves, then again, if you work with these hydrogels, you want them to be very weak for the biological properties, but that doesn't help you because if you have very weak materials and you put them under load-bearing, then they will fail very easily. So therefore, another technology we are working on, which we like to combine then, is where we do composites, where we combine now these hydrogels with materials fiber reinforced. So we have been embarking for a number of years on a process which is actually quite old, melt electrospinning, which has been abandoned by the polymer industry in the 50s and 60s because it's rather slow. But it's ideal for us because we are replacing another process which is used in many labs, which is called solution electrospinning. And you see here that a fiber based on a very high charge is formed, and you see this whipping motion, and that leads to that you get fibers if you do it right down to the nano range. And the philosophy was, if you have these fibers now, you can mimic the extracellular matrix. We use a different process where we are working out of the melt, and that allows us now to have a lot of control. So if you combine this now with the X, Y, Z movement, then you can really do very controlled structures. So here again, you have the solution electrospinning, so you get what we call a randomly organized non-woven, right? So when I come back now to that we want to really direct the biology, this is totally chaotic. So this doesn't allow you to do a lot of guiding. Plus also the pores are really small, so cells cannot penetrate. And here you see the close-ups. So with the melt electrospinning, you get a straight fiber. If you control this in X, Y, Z, then you get a very controlled architecture. And again, we can do the classical 3D printing that we also can take now CT scans or MRI scans, and we can make patient-specific and custom-made scaffolds with an internal architecture which allow us, if we know the biology, to really direct the biology. So how do we use those? So as I said, we are combining now the hydrogels with this fiber reinforcement systems. And as I mentioned, one big program in my lab is cartilage tissue engineering, articular cartilage tissue engineering. And we use this process now to make these box structures, which you can see here. It's actually a challenge to build scaffolds which are very high, because also this is a very complex process where you work with voltages up to 20,000 kilovolts. The fibers get charged and so on. But we can control this now very well. And you can see that we can make now porous structures which have porosities up to 98%. But the problem is, when we think about articular cartilage, this is a high load-bearing cartilage. It has a multiple architecture. We talk about 4 zones. then cartilage has about a stiffness of about 500 kilopascal to 1 megapascal. So when we look now at our meshes, then you see here that we are at about 15 kilopascal, and as we increase the porosity, we go very low. If we take our hydrogels, then we are in a similar range. If we do a cross-linking, which allows us to have, again, cell proliferation and ECM formation, then we are in the same range of 10 to 15 kilopascal. But the great thing is now, if you combine the system, and this melt electrospinning allows us now to go down to fiber dimensions also of 1 micron, then you see here that you get an up to 50-time increase of the mechanical properties of the system if you combine now the fibers with the hydrogels. So how does that work? The way it works is that on the specific designs we do, these box structures, when you place now the hydrogel inside, and the hydrogel maintains a lot of water, and if you put this under compression, the water tries to move out, but the water can only get to the fibers are put under tension, and that's how you increase these mechanical properties. And again, we have tested this in quite detail. Here you see the graphs for different strain rates. We do this with different bioinks, different biomaterials, and depending on the biomaterial, you see this increase of the mechanical properties between 20 to 50 times. But what about the biology? I talked about the biology. Here you see a long-term culture with human chondrocytes, which are the cells which you will find in the articular cartilage. And you see here that the cells produce very nicely the ECM you would like to see. This is then also shown here in the gene profile, but also on a protein level when we look at collagen 1 versus collagen type 2. So our articular cartilage is mainly made up of collagen type 2, that we get a very strong collagen type 2 formation in the system. So again, this allows us now really to direct this biology, and we are now starting large preclinical animal models because the results are very, very promising. All right, another big program in my lab is breast tissue engineering. And as I mentioned before, next to, and we heard it before, the multidisciplinary interface. So in my team, we also have engineers, we have material scientists, I have molecular and cell biologists, but I also have surgeons in my team. These large preclinical animal models are very important. But if you move now into this area of bioprinting and 3D fabrication, basically we also don't have an education of those engineers at the moment, which we would like to have, because they need to understand the engineering side, but also the biology and some of the medical side. So therefore we decided to come up also with an educational program, and we have been awarded the first dual master program, or we have designed it, but we have been awarded the funding.
From next year, students at QUT will be at the forefront of creating the medical marvels of the future. They'll be developing everything from bones to breasts to keep our bodies running longer. Christina Costalis has more.
It looks like a prickly sponge, but this 3D printed device could help women grow back new breasts after a mastectomy.
And my dream is that I'll be putting my hand up as the first person to have this type of implant.
Eliza Whiteside is a breast cancer survivor. She says the medical procedure, which could be available in just 2 years, would be life-changing.
The advantages of this particular type of implant was symmetry, the same volume.
The process to make the implant is called biofabrication. Layer by layer, 3D printers build the...
So we are very passionate about this, and we are now training students really on this interface. And this is done in collaboration with Wollongong, as well as the Medical Center in Utrecht and the University of Würzburg in Germany. So again, for breast tissue engineering, again, we have a lot of expertise in the country. And also one of the leading groups from the surgical side is the group of Wayne Morrison in Melbourne. And Wayne has been working with a local company, Anatomics, and they also developed and recently published this paper where they did a clinical trial where they used 3D printing in their initial work. And again, our concept is a little bit different. We are designing these implants patient-specific. So we are taking the laser scan or an MRI scan of the patient. which allows us then to model a scaffold which is patient-specific in respect to the shape, the volume, but we also think that the internal architecture is very important. But then also we combine this technique with a technique which is used already for a number of years in the clinic, and that is the liposuction procedure, where you take fat tissue from another part of the body and you inject it into the scaffold. Because in our philosophy, we think it's not possible to really do a classical tissue engineering approach where you seed cells on the scaffold and that you really are able to fill such a large volume. So again, the concept is based on also that we first implant the scaffold. The scaffold gets integrated, and then we use the body as a bioreactor. Because also from a lot of the studies, from my lab, but many other studies, the concept where we again culture cells on an implant and implant it into a defect, where you have no vasculature, where you have the initial immune response, that the cells are not surviving. So here the rationale is we first implant the scaffold. The vascularization comes after 4 to 6 weeks. The implant is nicely integrated. And then in a second minimal invasive procedure, we do the fat transplantation and inject the fat into the scaffold, where the cells from the fat find now a vascular bed, have a much higher chance of survival and therefore remodeling. And then complete regeneration, because we are using biodegradable polymers, which have been used in the clinic already many years for sutures, for plates and screws and so on. So we are in a number of large preclinical animal studies in pig models. Here you see one of the scaffolds. Here you see the procedure, which we do exactly the same way as you would do it in the clinic. And then here you see how I'm injecting the fat. And then we do histology as well as histomorphometry, where we look at that fat tissue. And here you see very nice remodeling. This is after just 3 months, where you get a very nice tissue formation through a scaffold, which has a very large volume. And here actually we tested out the smallest volume possible, which was only 20 milliliters of fat tissue in a scaffold which had more than 150 total milliliter volume. And then here you see in the analysis that we get much better results when we do this delayed injection of the fat tissue. So other technologies where we see this 3D printing going is that we also can now print a scaffold, patient-specific, and if we want to use cells, then we build the bioreactor directly around this process. And that, again, allows us to customize the process. Again, the science is very important. Here you see finite element modeling, where we are looking at the mechanical properties as well as the flow properties through such a scaffold. And here you see how it works. So the scaffold is inside. It's a closed system. And we are pumping in and out in an incubator now the media. And if you cut the system open, then you see a very nice flow profile of the cell culture media. So this is one of the directions. Another direction which we are also very passionate about is that we really have to come up with standards and definition, because the area is very hype, but obviously what we like to do is that the work from different labs are comparable, and they are only comparable if we do the same testing method. So we are working together with our American and European colleagues now on norms. Coming back now also to the educational side, we have been very fortunate that we were awarded an ARC PhD training center in the last round, where we now also, adding on our dual master program, have now a PhD program in place with very strong involvement of industries, where our PhD students will be placed in the company for at least 1 year with companies which are really already interested or are in the 3D printing field. And again, this is together with the University of Wollongong, Deakin, and MRTI. So again, we think this is really important to develop this next generation. Next to that is also that we are fostering spin-off companies in that program, that the students go out, not only with the knowledge, but also with the IP, which is developed in this training center. And we think this is a great chance for Australia to have a kind of a revival of the advanced manufacturing industry, because we have a lot of knowledge and expertise in the country. So again, the field is evolving. So recently I also accepted to be the editor-in-chief of a new journal named Journal of 3D Printing in Medicine. And this journal will have a large focus on the application in the medical field. Of course, what I have shown you is the work of great collaborators, great students, and postdocs. And I would like to thank them and acknowledge them, same as my funding agencies. And I thank you for your attention.
Thank you for a very inspiring talk. Questions?
I have a question with regard to your scaffolds. Do they have to be pre-treated with fibronectin or laminin or something to have the cells attaching them? Because different cells of different issues would not necessarily attach readily to different surfaces.
Mm-hmm. So the answer is they can be modified, and we modify them. So the simplest form is actually that we do a plasma treatment, because these surfaces are usually quite hydrophobic, to make them more hydrophilic. But then we can add on for specific cell type, fibronectin or vitronectin and so on. So as you said, it depends really on the cell type.
Thank you for the talk. I was wondering, with these material that's so porous and being made of plastic, will we need to develop new sterilization strategies? Because, I mean, a lot of the things like heat treatment, UV, ozone, plasmas will change the material as well. And as we implant these material, if they're not sterilized, would not increase the rate of infection?
Yeah, I mean, any implant needs to be sterile, right? So this really depends on which materials you are using. If you use the thermoplastic polymers, it's very simple. You do gamma irradiation, because it's the same material group as the suture materials. So that's not a big issue. And then you study in respect to the doses and so on, the changes in the molecular weight and so on. But they are packed usually in argon, so you prevent this. The bigger challenge is if you really do this 3D printing with the cells, right? Then you have no chance anymore afterwards to do a sterilization process, because that would kill the cells. So therefore, we are building entirely closed system, which are sterile, and every material which is used in that system is sterile. But the final product cannot be sterilized anymore. That is a much, much bigger challenge.
I have one question which reflects my cell biology bias. With the breast implant scaffold and the pre-vascularization model, what do the vessels grow into?
The vessels grow into the 80–90% porosity. So we design our scaffolds with very large pores, right? So when you think about the process, you first get the blood clot, right? And then the architecture becomes quite important, because the question is how that blood clot is now stabilized. And that relates to the fiber network. And that fiber network is built based on the pore architecture. So that's the way how we design that.
When you talk about printing 3D cells, these are cells that have the mechanical property of real cells, I suppose biological cells, but probably not too many of the biological properties like, well, electrical potentials and membrane properties and ionic flow in and out. And that's not the objective, as far as I see. Or do you see that happening in the future?
Yes, but again, the process is the same thing you do in your lab, and you seed the cells on tissue culture plastic, right? You trypsinize the cells, right? So this is very different what the cells do when they are trypsinized and then going down on your tissue culture plastic. It's the same for us, right? We harvest the cells, then they go into our bio-ink, and then they go through their biological process. And again, the key point I want to make is that the bio-ink we are using will direct this, right? So again, what you do in your lab is when you put them down on tissue culture plastic, you basically rely on the ingredients you have in the cell culture media, the growth factors and so on, right? So next to this stimulus, we add now a physical stimulus from the material, which we think will be stronger and better controllable by just using the paracrine effect.
So please join me in thanking Professor Hutmacher and the other speakers in this session for their very inspiring work. Thank you.